Good afternoon. I'm Mary Klopman, Dean of the School of Medicine at Duke, and it's my pleasure to welcome you to this virtual town hall on COVID-19. We are so pleased that it's virtual at this point in time and that we have the technology to be able to talk to you, but not in person. When we first thought about doing a town hall, it was really only 10 days ago, which seems like ages ago to all of us. And at that time, we thought it would be a great opportunity for you, engaged members of our Duke community, to be able to hear from our experts, to really be able to sort out what is fact versus all the things you might be hearing in social media that are actually not based on fact. Fast forward 10 days, we are now in the midst of a rapidly evolving challenge to this country, to our community, to our health system. And so I thought I'd start by telling you what we are doing. So we're focusing our efforts in two areas. One area is to absolutely minimize individual to individual transmission. And what we're doing here is following the same principles that is happening all over our country right now. So what does that mean to a university? It means virtualizing all classrooms, all didactics, and by the way, that has occurred in an amazingly short period of time. And for that, I'm very grateful to our educators that were so willing to take on new methods of teaching. For our clinical professional students, we are still having them in the clinical setting, but really restricting some of their activities, particularly not having them see patients in isolation, both as a safety maneuver, but also to limit the use of critical resources that we think we will need down the road. But we're evaluating that decision every day. From a research perspective, it means really thinking about what is essential and what is non-essential. So in the area of clinical trials, really non-essential clinical trials, putting them on hold, and that's both protecting our patients that are participating, but also making sure we don't have individuals coming into our health system that might actually be inadvertently spreading the virus. For laboratory research, which in the case of the School of Medicine is a massive enterprise, it really means trying to, again, minimize the number of people that are coming on campus and that can have opportunities for individual to individual spread. And so really using principles of distancing and only having one individual in a room at any given time. But again, that process is also an evolution where we really are moving towards minimizing the amount of research that we are doing real time in person. But of course, trying to make sure we keep the fundamental research going, particularly around the coronavirus outbreak, because we think we have a lot to contribute there, but also around critical clinical research that must go on. So you can see there are a lot of parts that are moving right now. For our staff, we are saying, please stay at home unless you need to be here to actually perform essential duties. And so we are practicing very much the same things that I think all of you have been told to practice in your communities. For our health system, which we'll hear more about, it's really not only thinking about how do we minimize the opportunity for infections to be transmitted within our environment, but also making sure we are scaling up and are ready to take care of the vulnerable patients that are really at risk for major complications. So that's kind of the big view of what we're doing, and to accomplish all that, the detail that must happen in a very rapid pace is simply mind-boggling, and I don't think any of us ever thought that we would be preparing for this scenario, but we are, and we're actively managing it. But today, we really wanted to be able to provide an opportunity to talk to you about some of the things that are on your minds, and I think you sent in questions. So first of all, I wanted to introduce my colleagues and fellow faculty that I'm so glad are here and helping us manage this unprecedented situation. So we have Chris Woods, who is co-director of the Hubert Jurgen Center for Public Health at Duke and chief of the Infectious Disease Division at the VA. We have Colin Duckett, who is my vice dean for clinical research. We have Joe Rogers, who's the chief medical officer for our health system. We've gotten your questions, and what I'm going to do is just kind of throw out the questions to our group and ask them to really chime in. I mean, I'll start it off, but really ask them to chime in. So I think one interesting question that you're hearing a lot in the news about is Is there historical precedent for what we're experiencing today, and can we learn anything from that? So I think my fellow infectious disease colleague is going to take a stab at that.
I guess I'll start with that. Thank you, Dr. Klopman. It's good to have the opportunity to speak with everyone. I've been working in outbreak investigations and emerging infections for most of my career, and have worked on the original H1N1 outbreak in 2009, where we addressed that locally, the Ebola response, as well as earlier in the early 1990s. And so I think there are many similarities, many attributes of the current outbreak that resemble things we've done before, but there are many that are absolutely unprecedented, which has made for a unique combination. If I think back to when we started preparing for pandemic responses, it was really at the end of the 1990s. We had heard about new avian strains of flu, and people worried that harkened back to the original 1918 avian flu outbreak, or when the first H1N1 actually occurred. That preparedness that took place was really important, because just a few years later, the initial SARS outbreak, what we call now SARS-1 coronavirus, because we're dealing now with the SARS-2 coronavirus, emerged out of southern China, and in a very similar fashion, but didn't have quite the same transmissibility that the current strain appears to have. And there were 8,000 cases and about 800 deaths, for about a 10% case fatality rate with that outbreak. But it was an unprecedented response globally. Then when the 2009 came around, and the H1 pandemic, which took off early, we thought it was going to be the next replication of the 1918 situation, because there was reported a very high case fatality rate early on. But as that pathogen, or that virus, transmitted around the world, we learned more and more about it, and the case fatality rate dropped substantially. We're not necessarily seeing that drop now. But one of the real interesting things with that particular outbreak is it was targeted those under 65 years of age, and had a particular bad course in our young people, who had a very low rate of pre-existing antibody in that situation. Also targeting individuals who were obese and pregnant women. And so we're applying many of those lessons to our situation today. This one is different. We have, it's targeting a different vulnerable population, the older folks, and we'll talk more about that, I'm sure, as we move on. But there are, as I said, many attributes that are quite similar to what we've seen before, but unprecedented in scope, given the transmissibility we're seeing and the maintenance of the relatively high attack rate.
Now, the only thing that I would add to that is, and probably this is showing my age, but having been around when HIV was a new pathogen, really using the information at hand to rapidly inform you really helps you make reasonable and rational decisions on everything from prevention to planning what you need to know, your research around what you need to know. That being said, it seems to be something a little bit different each time. So let's talk a little bit about the vulnerable population. I think that is, the data so far really does support this idea that this is uniquely, in terms of real disease, uniquely in the elderly population. And so, Joe, you might talk a little bit about why that is and what that looks like.
Yeah, thanks, Dean Klopman. And I'll extend my appreciation for all of you joining us today. As you stated, there does seem to be a real increase in severity of illness and risk for mortality as age increases. And the people that seem to be particularly vulnerable are those who are older than 80 years of age. Interestingly, yesterday we began to see reports from France suggesting that there was a clustering of advanced illness in a younger population. And I think we're still trying to dig into that and understand A, whether it's real, and B, why that difference might be seen, because it's distinctly different from what was reported in China and what's being seen in Italy. So the older population seems to be particularly at risk for more difficult clinical courses with the illness.
Joe, just before you go on, in that older age group, do you have in watching the data that's coming out, where does that risk start increasing?
Yeah, it looks to me, thank you, it looks to me like it begins to increase at about 60 years of age or so. I mean, there's a sort of a very gradual increase, but you really get to that inflection point once people begin to get over the age of 60 and 70, and then it really goes up significantly, over the age of 80. The other things that seem to be coming out in the reports are that individuals who have heart disease, lung disease, diabetes has come out in a couple of risk models, and those who are immunosuppressed, so organ transplant patients, people who take immunosuppressive kinds of medicines or have an intrinsic disease that makes their immune system less robust, seem to also be at high risk.
Chris, have you seen anything else that kind of would allow you to predict risk? Its age, its comorbidities?
Age, as Dr. Rogers was saying, this group of individuals, we're making presumptions a little bit from the experiences before that pregnant women, for example, and there has not been effects on large numbers of transplant patients. We have the expectation that that group is going to be at greater risk, and are emphasizing most of our strategies for containment and risk mitigation around cocooning those higher risk people accordingly. We will be learning more. As we stated, this is a very dynamic situation, and as the virus moves, it's liable to change slowly, but and the different population it encounters along the way may react differently, and that seems to be maybe the case what's going on in France.
So one clear difference between this and flu, and there's a lot of differences, is we don't have an approved antiviral. You want to talk about what there is coming down the pipeline for therapeutics?
Yeah, so this is one of the more exciting areas taking place, and it is one of the great frustrations. It's very reminiscent of what we dealt with during the Ebola outbreak, where there were a number of therapeutics that were on the edge of becoming available and had not been fully developed to the point of full approval. So we had to initiate clinical research during the time. And this is where we are now. We don't have specific therapies for this particular virus. So most of what we're relying on is excellent supportive care, prevention, and then as people develop more severe manifestations, relying on our technologies that we have in place at places like Duke to help support those individuals. But there are a lot of exciting things moving forward. One particular drug by Gilead called remdesivir has been brought forth initially as an potential Ebola therapeutic, but it did not perform better than some of the other agents that were made specific for Ebola. And it's a broadly active antiviral, and has been used in at least one clinical trial in China, the results of which people are very much anticipating. But it's also the key drug in a upcoming NIH, or a trial that NIH has initiated that is assessing the performance of that drug in a randomized fashion, because we don't have randomized data to support any of these potential therapies. But there's a long list that the Chinese initiated probably 100 different trials using a variety of repurposed drugs, including traditional Chinese medicines. So we're expecting to see a lot of data coming out soon, but we are initiating many of our own trials here in the United States, again with a number of both antiviral specific drugs, drugs that are affecting the host response as well, and also,
Well, I was thrilled to hear that our site has been picked as one of the sites to participate in the clinical trial. So when and if we need it, hopefully we'll be able to offer that to our patients. And one of the reasons we have been picked is because we're organized to be able to get things up and going, which I think is one of the major potential impacts that academic health systems can have, is to mobilize the opportunity to really get things studied very, very fast. The other big thing everybody's talking about is there a way to prevent this? And of course, that would be through largely a vaccine. There is not a vaccine currently, but a lot of work going on. So Colin, you might talk a little bit about some of the work here. By the way, I am so proud of our faculty that have kind of heard the call to arms and really mobilized around doing an amazing job in getting our research really refocused on this issue. So talk a little bit about what's going on here.
Yeah, and to that point, and to Dr. Woods' point earlier, one of the things that I think is different about this pandemic is how quickly the world has mobilized against it and how much we've learned so quickly about this. But specifically to the vaccine question, which is certainly one of the most important, and it's one that we are asked regularly, as you can imagine. The development of a vaccine is something that isn't going to happen overnight. We're going to have to look at vaccines that are coming through that we're developing here, that are being developed around the world, and we're going to have to ask the question, are they effective, and also are they safe? And so as we go through this work, and as we learn more about how we're going to be able to fight this pandemic, I think we have to look very hard at that. You'll see that there are trials that are underway already with some really interesting technologies that we have here, as do many other institutions, and we'll see whether those small-scale trials are ones that will be able to be extended to a larger population. So there's a lot of work to go. I think realistically, we would think that a vaccine is perhaps a year away at least, is a more reasonable time frame to think about.
So Chris, you might talk a little bit about why a year, because this is a point that has been missed, and I think really an important point.
Yeah, so there's opportunities. One thing I would want to mention right off the bat is this is an opportunity that we want to take all the way through. As we experienced, again, I'm going to harken back to the Ebola situation. There had been products developed almost to the point of delivery, and then the money and the effort had dried up, and they weren't pushed all the way through. So regardless of what happens in the course of this particular outbreak, I think there's a call to push things through to completion so that we're ready at least the next time things come around, or if there are subsequent seasons down the road. But the process to bring a product as complex as a modern vaccine, particularly in the case of some of the products that are we're considering now, is very complex. There's a series of studies that must be done to assure the safe implementation, and we walk through the different phases. There's a preclinical phase where animal studies are done. Then there's a first-in-human phase where we assess the safety, at least in the acute phase, and then you start moving into phases where you're assessing the ability of the vaccine to actually prevent disease. That's done best when you have ongoing disease transmission, which is one reason sometimes new vaccine candidates aren't taken all the way through, because there's not ongoing transmission. And obviously in this situation, you have a new pathogen. But we also need the tools to investigate whether or not the actual vaccine is effective, meaning we have to monitor the antibody response or monitor other immunological responses that are likely to predict the ability of the vaccine to be effective. And that, in many situations, is many, many years. In this situation, as Dr. Ducken mentioned, we're looking at least a year to 18 months out to go through that entire process. I think it's incredibly exciting to hear, though, that they've already started.
They've enrolled patients already.
Patients in that.
Yeah, I do want to emphasize the point that phase 1 safety is so important. Chris and I both know a number of infectious diseases where conceptually a vaccine made sense, scientifically it made sense, but you get into a phase 1 and you find actually it makes the disease worse. And now we know there's a lot of immunologic basis to that. So the safety cannot be skipped, particularly in a vaccine that might go into millions. So it's probably going to be a year to year and a half. But I want to talk a little bit about what we're doing here to really put candidates in the clinic as rapidly as we can. So we have a vaccine institute very much focused for many years on HIV. But over the years, we've developed a lot of tools and a lot of technology and a lot of understanding of science, of the science of delivery of vaccines, to be able to apply that to a number of pathogens. And so Bart Haynes and his group now has a candidate vaccine. They're using our cryo-EM facility to really look at the protein that we think is going to be the effective immunogen, put that on a nanoparticle platform, and already proposing to the NIH to get that in non-human primates very fast to rapidly go into the clinic. So that's where we can really move things based on everything we've developed for another disease, but being able to pivot very rapidly. The other thing you might talk about, Colin, is why Duke? Why we can do some work with this virus here now.
Right, so the vaccine work that the DHVI has been doing has really taken two prongs, I would say. It's the approach of looking at the virus itself and developing parts of the virus that can be introduced as a traditional vaccine to give you the standard type of vaccination that is tried and tested that we know about. But these really remarkable experimental vaccines that have got so much promise, where you can bypass those steps and you can develop a vaccine much more quickly, where in which you immunize with genetic material that encodes that particular part of the virus. Those are looking really promising. We couldn't really have done that work without the infrastructure that we've created over the last 20 years in the Human Vaccine Institute. So I think a really powerful part of that is the Regional Biocontainment Laboratory that we have here. So we're part of a DARPA-sponsored initiative.
I just want to say that containment facility came up after 9/11, when the country was very concerned that there'd be weaponized pathogens. But we were one of the sites, and one of the commitments was to keep that going for 20 plus years. So fast forward 19 years, and we're using that facility to look at this virus.
That's right, and I think every outbreak that we've looked at, we've learned from so much work from our predecessors. But to put that program together, one of 14 consortia institutions in the country that are funded in a very long view, just as Dean Klopman said, over 20 years where we've been developing that program, allows us to look at the virus, allows us to amplify it, to analyze it, to understand the genetic material that encodes that virus, and to be able to move forward into those kinds of really high throughput, high speed programs. It's just astonishing that we can do that here at Duke. So that's certainly one of the programs in terms of research that is giving us cause for optimism, that we have both the traditional tried and tested methods of developing vaccines and the work of Dr. Haynes and his team, especially with our cryo-EM program, especially with some of our really remarkable strengths in immunology, are allowing us to understand whether that's going to be the way forward, or whether it's going to be one of these new technologies that we and others around the world are developing that would allow us to bypass those processes. Yeah.
But this DARPA grant that we got in 2016 was to prepare us for exactly this scenario. It was an opportunity for Duke to convince the government that an unknown pathogen all of a sudden was identified. What would be our strategy, and what is the timeline for us to be able to come up very, very rapidly with something that might be used at least therapeutically? So in this case, we got the grant, and the therapeutic opportunity is to use individuals infected with, in this case, coronavirus, their blood, to be able to pull out a B cell that is making an antibody that might turn into a therapeutic. And so again, using the platform of technology already established, using patient samples in our biocontainment lab, the opportunity is to really advance something very rapidly that otherwise would take years. So keep your fingers crossed, because I think this is another example of an exciting opportunity in research that then could be translated rapidly into a therapy. So we're doing a lot in the space of research in basic discovery science, clinical trials, and then the translational science, where we're trying to move things rapidly along the pathway of a vaccine or a therapeutic. But turning to our health system, because that's the front line right now, North Carolina is going to experience rapid increase in the number of cases. We know that. Talk a little bit about how our health system is getting ready.
Yeah, thank you. It's really been an all-hands-on-deck effort for several weeks as we've watched the disease enter the United States in Washington and then begin to spread across the country. And so we've taken a number of steps, been very methodical in our thinking, in our planning, and remembering, of course, that we're a health system and we have not only the Duke University Hospital, but we have 2 community hospitals that are affiliated with us, and then a series of other hospitals that either refer patients to us or we have the LifePoint network, and we're also worried about them and trying to help them prepare. We've taken several steps to try to begin our preparations. We began by limiting patient and visitor access into the facilities, and we implemented that over the weekend. We're asking that we only have one individual accompany a patient and no minors coming into the facility, trying to propose and exemplify this idea of social distancing. In addition, we've begun to work on trying to thin our clinics out a little bit and ensure that we're not bringing people into a healthcare environment that may be susceptible to infections, and trying to limit the throughput through some of our clinics to create a capacity to manage those patients. We've ramped up our testing abilities, and just in the last day, we have opened up some drive-by screening clinics that will be by appointment only right now, when we're using our telemedicine platform to screen those patients and try to determine who should be tested and who can safely forego testing. With regards to our inpatient facilities, we've done a number of things, really preparing for what many people are concerned about, and that's this surge that everyone's talking about, and that's this rapid increase in the number of very ill patients that require hospitalization and advanced care. And to address that, we have organized our platforms so that our intensive care units are prepared to manage this patient population. We've begun thinking about how we're going to stage reducing the number of patients that we have in the hospital through strategies like stopping our elective surgical procedures to create a capacity for the patients. And the other thing that's really important to us is that we've spent a significant amount of time with our staff and our physicians, preparing them for what this could potentially look like, making sure that they will be safe in a healthcare environment. And you can imagine that just like the general population, our healthcare providers share that anxiety about what this could look like, and especially if we have a large concentration of patients that have the disease in our environment. So we spent a lot of time making sure that they understand how to use personal protective equipment. I know everyone on the webcast has been hearing about these N95 masks, making sure that the people understand how to put those on, take them off so that they're not cross-contaminating themselves. So those are a lot of the steps that the health system has taken so far. The other thing that we've spent time on, just so that you're in the loop, is thinking about our supply chain. And you can imagine the incredible pressures that are being placed because of the demand on personal protective equipment. The thing that we've recognized even today is that there's going to become a national shortage of nasal swabs. So things that we sort of have taken for granted always in healthcare, we've always had enough. We're beginning to think about how to really utilize our tools as optimally as possible, and then begun thinking about alternative strategies. If we run out of swabs, for example, how do you begin to sample those patients? So we've come up with some fairly clever ideas about things that we may try to implement. And then I think this last piece that the health system has really tried to focus on is being a source of truth for what we know about the virus. And what we really know about the virus is that about 80% of people who contract coronavirus, this COVID-19, have a flu-like illness. And so I completely understand the incredible anxiety around this, but I think it's also helpful for us to continue to frame this up and remind people that the vast majority of patients that will contract COVID-19 will have a flu-like illness that will maybe have a little bit prolonged course, but they will be okay. And what we really need to spend a lot of time then on is focusing on this other 20% who's going to get, who has the potential to get quite ill.
Yeah. No, I agree. I think the fear of a real sort of infection that affects you personally is driving some people's behavior, but the absence of that fear is also driving some behavior that we don't want, which is people feeling like, you know, it's not going to affect me. I think the major principle is everybody can be a vector for this virus, whether you're symptomatic, you're not symptomatic, whether you're young or you're old. And so I guess one of my messages to everybody watching this is really pay attention to what your local communities and leaders are telling you. Even if you're young and healthy and have no other disease, none of us want to be the person that spreads this infection. We all know that this is a very, very important public health intervention. And so great that you're young. I'm not. But I think this is a message that we're really trying to get to everybody, which is heed your local advice in terms of really social distancing, not going out currently, and listening to what your leaders are telling you locally. A couple other quick questions. I know we don't have too much time. There was one question about, are we learning from other countries' experiences? I'd say absolutely yes. Chris, you wanted 2 or 3 points that we've learned?
Yeah, so we are lucky in that we are somewhat later in the experience here, so we do have the opportunity to learn from a lot of what has happened. And we do know that in a unique way, with a very unique government situation, China has been able to control a situation, apparently, based on the data we've seen, that had rapidly expanded, affecting 80,000 persons, and now down to transmission rates of each day being quite low. So they've demonstrated that with very aggressive containment activities and the use of newer technologies and the use of a lot of techniques that probably would not be acceptable in either European or here in the US, they were able to contain a very large outbreak. However, there's elements of that we are imposing. Social distancing, the focus on protecting our most vulnerable, that are important. And we probably can't impose the same level of restrictions that our Chinese colleagues were able to achieve. You know, we can make significant headroad into actually reducing, or they talk about flattening that curve. Everyone's heard that now. As we look to the idea there is to, you know, avoid that surge that Dr. Rogers was talking about, reduce the number of cases overall, reducing transmission amongst all of our population. That allows us, allows our health system to deal with the cases that come through, and gives us time, buys us time to potentially develop some of those countermeasures that are moving forward. And we're learning a lot along those lines about, as I mentioned, all of these studies that took place in China that are ongoing in Western Europe right now that we'll have the opportunity to employ here. I did want to take just 1 second and say a special thank you to our public health community you had mentioned before. It really is a remarkable group. The team at CDC, the team here in North Carolina, the team locally who are doing our infection control. This is a really dedicated group. And
our old colleague during HIV days, Anthony Fauci.
Tony Fauci is a great example. And they've not necessarily been held up in great esteem through this initial reaction. And I think that they deserved our respect and they deserve our appreciation for everything that's going on right now.
Absolutely, and I'm so appreciative of my colleagues. I always love to say, I never want to be the smartest in the room, so thank you all. And to all of you who are really valued Duke colleagues, we love being able to provide you information. I'm glad that it's virtual. I've had a lot of you reach out and say, how can we help? I think virtual reaching out is good right now. We're not going to be inviting groups to campus, but we do want to stay in touch. Some of you have offered resources, and I would say thank you very much. We would love any support for some of the ongoing work, but mostly your support in terms of being cheerleaders for what we're doing, but also being leaders in your own communities to make sure everybody is listening to the advice that we are hearing now on a regular basis. So all of you be well, and I hope to hear from you again soon. Thank you.